May I call Dr. Mahesh Karigoudar? And may I request Dr. Rama Manchanda Madam to chair the session again, please?
We are now ready to listen to IPF, again, the problems, the small cells, and Dr. Mahesh Karigoudar. Is that right?
Yes, ma'am.
Okay, thank you. He's a consultant at the Diagnostic Laboratories and Professor of Pathology, BLD University, formerly, and presently is the consultant pathologist at his own lab. That is your Karigoudar Diagnostic Laboratory.
Yes, ma'am.
A lot of publication, lot of work he has been doing. His main interest is in histopathology, hematology, cytology. Diverse interests, but I'm sure he's focusing more on the dots that he's going to talk about, IPF and bone marrow in hematological disorders. Welcome, Dr. Mahesh.
Thank you, madam. This Vijaypur is a very small place. Dr. Eri is, both of us are in Vijaypur. It's a very around 5 to 6 lakhs population. And we struggle to give the more accurate, reliable, and we discuss with the clinicians. And in the last few years, a lot of new parameters have come in. So we started using that one. Regarding this, we use this IPF in a day-to-day practice. Coming to the immature platelet fraction, this we know that they have been introduced in last 1 or 2 decades ago, and IPF represents the subsets of platelets. It's the early platelets which has got a high RNA contents, and they represent the most recently released from the bone marrow into the peripheral blood. They are analogs to the reticulocytes of RBCs, and it can only be measured by the cell counters. The why this study, I have taken it because there are certain reasons are there. There was a need of IPF in 2015 and 16 because of dengue outbreak, and many cases were needed IPF, and we procured the 5-part differential with the Retic mode. And it has benefited a lot of patients during that time. And we used to do reticulocytes only on request, and you know that outbreaks. Then going back to the, in 2000 plus, where I began my career there, we used to do peripheral smear because we got some of the pathologist lab there, and many of the small cell counters they used to run, and they send the peripheral smear to us. Then soon we realized that the count on manual, when it comes to low, normal or something like it was very difficult. Then we started using all the peripheral smears with 3 parts. That was our mandatory in my lab. And it gives a confidence for me as a pathologist, and clinicians and patients are also happy. And we used to do reticulocytes manually. And once we bought this 5-part, so instead of using the reagent, we just marginally raised the charge fees of peripheral smear by around 20, 30 or 50 rupees. And we started running the peripheral smears with these counts with the Retic and IPF mode. And at the same time we are consuming the reagents, we also got some more information in our day-to-day practice. And in certain cases, it really helped us to arrive at the diagnosis. And whenever the bone marrow comes, we do a peripheral smear with CBC and Retic. All data will be there when the slides are ready. With this, I'll just give an example. In the month of March, just last month, we had a case, 4 years, female child, anemia and mild splenomegaly. Clinicians were of doubt having this thalassemia or something else. They sent a peripheral smear, HB electrophoresis, and set of investigations. And peripheral showed the normocytic with normochromia and few spirocytes. And we ran electrophoresis was near normal, except that HbF was mildly raised. Then DCT was negative, ANA was negative, osmotic fragility was mildly elevated, HB electrophoresis was normal, and this our CBC Retic count gave 13.9%. Then we did a manual stain, nice hinge bodies, and we just reviewed our slide, bite cells were there. So this is a case of G6PD. Now coming to the CBC, IPF and the bone marrow pathology. In the subconscious, I'm sure that it was helping me a lot, but I didn't have a data. So with this, Mindray called me, why can't you do some study and do it? Then I took a data of this one. I took a bone marrow data from Jan 21 to August 23 for 32 months. And we we included that all the causes of thrombocytopenia, let it be clubbed together. So it can be a reduced thrombopoiesis or increased platelet destruction or consumptions, or it can be abnormal distribution like sequestration, what it happens in fibrosis or something else. And we included all the cases where bone marrow data is available, platelet parameters and IPFs were available. So in this 32 months, we had a data of 562 bone marrow aspirate and 112 biopsy. And this is with a gender distribution is almost equal, and age distribution started with the 4 months to 85 years data was there. And we case filtered based on the causative factor for thrombocytopenia. So we divided into these 5 categories: ITP, megaloblastic anemia, hypocellular aplastic anemia, acute leukemia, or myeloproliferative, particularly the MDS and myelofibrosis. So in total, around 200 cases we had. Then we started taking about the each data. ITP comprised around 65 cases, and I don't want to go into that age and gender distribution. And then this is ITP having all megakaryocytes normal to hypercellular, and many are having a hypolobulated or a small platelets, megakaryocytes, what you call it, the exhausted megakaryocytes. Then megaloblastic, we had 48 cases. This is pure megaloblastic, not a mixed erythroid or pure megaloblastic. This is a very nice megaloblast in the bone marrow aspirate. Then we had around 11 cases of aplastic anemia or a hypocellular marrow. One interesting point that this hypocellular marrow were common in the early period of decades in life and in the later period. One example in June 2021, just after the COVID outbreak or during the COVID outbreak, that 50 years male patient, he has recovered from the COVID pneumonia with the 18 score, and after 2 months, he was readmitted with the breathlessness. No, during COVID, many were thinking about COVID. And CBC had showed that 2,900 cell count, HB is around 8% and platelets around 80,000. Then we received a peripheral smear, and peripheral smear we ran with all CBC Retic. Then it showed NC with pancytopenia, and IPF was around 1.6. Then somehow that I should convey this to the clinician. Then we conveyed that platelets are likely to deteriorate. Then we did a day 2 repeat platelets 0.62 lakhs and IPF dipped to 1.5, and we advised for the bone marrow. And it did show hypercellular marrow with few megakaryocytes were there, and unfortunately, a lot of histiocytes were there with a lymphocytic phagocytosis, then erythroid phagocytosis, and this is a case of HLS syndrome. Probably it's a COVID-induced, so we don't know exactly, and patient succumbed within a week. And it has been proved with ferritin, triglycerides, LDH, and fibrinogens. Acute leukemia, we had around 56 cases, and these are various blasts in the smears. And myelodysplastic syndrome and myelofibrosis, we had around 20 cases. Now, once we started doing the biopsies, a lot of cases has been picked up. And this is again an interesting case. Is a 65 years male, is an alcoholic and had a cirrhosis of mild grade with splenomegaly. He admitted with the pain abdomen. Ultrasound shows there is a splenic vein thrombosis. And count showed 4,100 cells, 10.5 HB, and platelet is 1.7 lakhs. And as you know that whenever we receive peripheral smear, we do all these things, and IPF was 12.1. Somehow that is not matching, and we discussed with the clinician whether steroids have been given or something like that, and he conveyed that his record shows splenomegaly from 5 to 6 years, and it is disproportionate large with the grade of a cirrhosis. And they also wanted to find the cause for this. So we advised for the bone marrow here, and unfortunately he landed with the emergency splenectomy was done on the day 4. And this is bone marrow aspirate shows a lot of megakaryocytes with the dysplastic features, and biopsies showed that there's a clustering of megakaryocytes and there is abnormal localization toward the trabeculae. And reticulin showed a grade 3 fibrosis, and splenectomy had showed that extramedullary hematopoiesis with presence of megakaryocytes. And this is a case of a myelofibrosis. Then we had data of around 200 plus cases, and we tried to put it in a chart. Initially, when we put it in a chart, I couldn't understand how to make out. Same as with the IPF. Then we started plotting this in a box and whisker plot diagrams. We did for the ITP, megaloblast, hypoaplastic anemias, acute leukemias, and this myelodysplastic myelofibrosis. Then when we see the individually, it's very difficult to make out that what is the increase and this thing at this thing. So we clubbed in one by one, one next to the next, and let me remove this platelet, this count dots here. Let it make it simpler. And there are a few cases you can see in the top. They are outliers. They are not counted in the statistical. Same as we did for the IPF. Then let me combine these together. When we put it one below the other, the interesting findings came out. The ITP has got a low platelets and a high IPF. Aplastic anemias, the low platelets or the pancytopenia, but there was always a low IPF. Then megaloblastic anemia, we got a variable platelet count, but near normal IPF. Then acute leukemia, low platelets, normal IPF. The Sukesh sir, what he has said that they are always the early platelet because the amount of productions are reduced, but the release is same pattern, right? Then what about the myelodysplastic syndromes? We got a variable platelets, normal to high IPF. So we started using this IPF in a day-to-day practice so that this data, what we coming out is appears to be quite interesting. Then we just went to the literature. This is a South Korean article. They studied this thrombocytopenia and predicting the platelet recovery with the 5 of the parameters, which has been extensively discussed. And they also added one parameter, that absolute immature platelet concentrate. And they came out with that this is significantly higher in hyperdestructive or consumptive thrombocytopenia, the same what we found. Then one larger study has happened in UK. They categorized this thrombocytopenia cases into 6 groups. They included the reduced thrombopoiesis, ITP, infection, hemorrhage into increased consumption, drugs, abnormal distributions like splenic sequestration, and they also included the platelet clump and satellitism as a one more group. And they found that this immature platelet fraction, they are increased in increased consumption category as well as thrombocytopenia. And this is a study done in Philadelphia. They included 127 ITP cases and 21 cases of bone marrow failure or the aplastic anemia. And the findings were exactly same, almost same as what we got in our study. The IPF there we got 16.6% as a mean, and we got 15.5. And in bone marrow failure or the aplastic anemia, they got around 2.9%. We got around 3.2%. And myelodysplastic, one interesting article also we came across. They got on 37 cases of myelodysplastic, and they had, again, the platelets are variable, IPF were also variable. They categorized into A1, A2, and B1, B2 based on the platelet number and the IPF numbers. And they came out that certain patients are having a high IPF level, and they explained that probably they are due to increased proliferation of normal megakaryocytes, or it can be a atypical differentiations of the megakaryocytes. And in summary, we studied around 201 bone marrow cases as a cause of thrombocytopenia, and we divided into 5 etiological conditions, and we found that IPF is really high in ITP and is low in aplastic anemias. And with the introduction of CBC Retic, IPF in peripheral smear and bone marrow has helped me to pick up a certain cause for this thrombocytopenia, and we could recommend or we could advise the bone marrow biopsy or aspiration at the earliest period. And this has helped the clinician for the appropriate treatment and so as to reduce the hospital stay for the patients. And this is how we try to connect the dots. We have data, we have peripheral smear, we have a CBC. You have to just look into all the parameters with the relevant clinical history and the bone marrow findings. We can connect the dots to the various etiology. And this is my take-home message about use this parameters in your day-to-day practice. Definitely it will help you. These are my references. Thank you.
So much. Yes, lots has been talked about, and we'll keep on talking about MPV and IPF. Any questions, any thoughts? Yes.
Very, very well presented. In fact, I'll say that you have taken the IPF to the next level and little away from dengue, which is very good. And you have studied the IPF in all the other bone marrow disorders now. Now, surprisingly, one observation that I've seen in your study is that in MDS, you find that the IPF is high to normal to high.
Yes.
And that's a surprise to us because in our cases, we have most of the times found that in MDS, the IPF is low. In fact, that used to give us the confidence to report it as MDS because we thought that it is going to be low. Now, there were 2 or 3 cases in which the IPF was high and they were MDS, so we were very surprised at why. Now, but I think we should have been surprised with the other way around, considering what you have found. But this is a new thing for us to figure out that the IPF in MDS is actually high, whereas we always thought it's low. So, but probably you've given the reason as mentioned
Yes,
in that
yes.
paper.
They are mentioned in the literature. They are increased production from the existing macrocyte or is an abnormal response from the macrocytes.
Yes, but most of our cases have showed us low IPF.
The
I'll
even-
keep a follow-up of the
Yes, yes. Even
further
we had a
MDS.
low platelet, but certain cases are very high.
So
They were
all-
disproportionate.
So in all these cases of MDS, has it been proven cytogenetically that they are MDS,
Yeah,
or is
not
it just
all,
the
madam.
morphology?
I think around 8 cases they have proven it.
Only 8 cases
Yes,
out of
yes.
how many
Out of 20,
cases?
out of 20.
20.
Yeah.
And rest of them are based on the morphological.
Yes.
And they have been treated like MDS.
Yes. And I clubbed both this MDS and myelofibrosis because I have got a data very less. Probably
Okay.
that is the reason that in my outcome there is a variable platelet counts.
All right.
Let me check that only pure MDS, what will be there.
All right. I think we'll just do a follow-up on our
Yes.
cases also now. Thank you. It
Thank
was
you.
lovely.
Thank you, madam.
Thank you, Dr. Tadu. Thank you so much for your nice
One-
presentation. Any other question, comments? Yes, yes,
I
please.
was not going to after the intervention
Yes.
of the. I think I have studied MDS, also megaloblastic anemia, and other situations of ineffective erythropoiesis, and I have found that not all the MDS, but some MDS have high IRF and normal retics. That is defined as ineffective erythropoiesis, and the same with IPF, high IPF
Yes, ma'am.
with low platelets. That is also, but not all of them. Will be interesting to know if the group of patients of MDS with ineffective thrombopoiesis and ineffective erythropoiesis respond differently to the therapies.
Yes.
And to do a clinical study, if these parameters have a clinical use, this fact, the ineffective thrombopoiesis and erythropoiesis have any value to predict the response to the therapies for MDS.
Yes, Dr. Rajesh.
Yeah, to your comment, means I can give you one additional thing. Some of the MDS patients have been treated with steroids and they respond very well. So are these patients who are having the high IRF and IPF, which are, so maybe we can do a study on.
Thank you so much.